Thank you so much for your time. And I've given a brief overview of community engaged research. And if you have any questions, please feel free to reach out. But now we're going to shift gears and have a panel discussion facilitated by Reverend Hickman with panelists who represent different aspects of conducting community engaged research, whether it's from the researcher side with Dr. Janice Bowie, or from the perspective of those who have partnered successfully with other researchers, with Rhonda Ford Chatmon and Michelle Simmons.
Thank you very much, Chidema, for your presentation, and Dr. Cooper, and thank you for allowing me this opportunity to actually moderate this session. I'd like to thank all of you again for joining us this afternoon, and I'm quite certain that we will have a very robust discussion. For those of you who may not know me, I am Reverend Debra Hickman. I co-lead the Community Engagement Core with Drs. Cooper and eBay. And I am the Executive Director for Sisters Together and Reaching. It's my pleasure to welcome each of you all to the next portion of our time together. A discussion with our esteemed panelists representing various perspectives. Joining me are Dr. Janice Bowie, Ms. Rhonda Ford Chatmon, and Ms. Michelle Simmons. And so just to give you some background on them before we get actually started with a question and answer series, Dr. Janice Bowie is the Professor of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. She is the chair of the Doctor of Public Health Programs and is a leading expert in conducting community-based research methods, which she has championed over her outstanding career at Hopkins. And then we have with us Ms. Rhonda Ford Chatmon. She is the Vice President of Health Strategies for the American Heart Association in the Greater Maryland region. She has been a member of ALCAB for several years now and has a deep passion for supporting supporting underserved communities in this area. And last but not least on our panel is Ms. Michelle Simmons, a lifetime resident of Baltimore City. She is a patient advocate with over 40 years of experience engaging with and leading members of the West Baltimore community. She is an original member of the Community Advisory Board and serves as a co-investigator in the Community Engagement Core of the newly funded Mid-Atlantic Center for Cardiometabolic Health Equity. And so we will not waste any time so we can get all of our questions answered. And we are going to start with the beautiful Dr. Janice Bowie. And one of the things that has been mentioned in the overview on community engaged research was the importance of us focusing on issues that are important to the community. In your work, Dr. Bowie, how have you gone about learning what community members view to be the most pressing health and social issues affecting them?
Thank you so much, Reverend Hickman and Drs. eBay, and I'm delighted to be here with the co-presenters, with Ms. Chatmon and Ms. Simmons. And I first just like to dispense with doctor, and please just call me Janice. I'm much more comfortable with that versus the formal title. I would answer your question by saying that in terms of my experiences and my training, what I have found is that I know less. The more I do this work, the less I know and understand. And oftentimes I end up having to dispense with my textbook training and really have to go deep into what are the motivations for why I do the work that I do, and what is it that I value. And what I have learned from my community partners and community members is that that I need to understand what is important and valuable to them. And sometimes that has to happen before we enter into community engaged research with them. Sometimes the nature of our work doesn't allow for that. We have a different set of metrics for those of us who work in academic spaces. We're required to write grants. We're required to obtain grant funding. We're required to publish. All those things keep us in our jobs and help us get promoted. And particularly for people of color and women of color who are in the academy, we fully understand this. But why I'm saying that as a way to set up my response to your question, Reverend Hickman, is that we have to be real clear and transparent with our community partners as to what the expectations are. When we enter into these relationships prior to a particular research project, the better are our chances to have those relationships with us throughout that process. When it comes later, it's also a bit more of a challenge. Sometimes we end up all the way at the dissemination stage before we are now trying to build a relationship and have community partners with us. So the earlier that process starts, the more likelihood will be that alignment between what it is that we're proposing to do and what the community determines is important to them. But in the cases when that is not happening, there has to be that clarity of expectations so that you are entering as the community partner, making an informed decision to come in at whatever stage, understanding what it is that we are going to do in this grant. And that way, at least you are agreeing that you as an organization representing consumers or the intended beneficiaries of a project or research study understand what is to take place. Mm-hmm. I want to go back to say why I make that distinction between community organizations and consumers and intended beneficiaries is because there still is a hierarchy that is happening. And the community organization is there to represent the community members oftentimes, but you need input from those members as well. So don't think that just because you have partners through organizations, that is reflecting the alignment with the intended beneficiaries. You need to make sure that you also are reaching those beneficiaries, the individuals who are going to be affected or impacted by this research project, to make sure that that alignment is there. When that alignment is not quite there, the question that most of my students over the years always pump me for is, what happens when you get that grant and that grant isn't what the community wants? Let's say that, you know, your intervention is focusing on smoking cessation, classic. And you're focusing on smoking cessation, and that's not where they are. They are wanting to figure out, how do we keep certain environmental hazards out of our communities? So this is how I have often approached my work. The grant says I'm to deal with smoking cessation. I try to make that clear, that that expectation is that that's what I have to do. But the grant didn't say I couldn't also do and try to help address these other issues. And sometimes I may not have the expertise to even know what to do, but it doesn't mean that I can't either bring some other resources to the table or at least try to make known what those other concerns are to other organizations to help them to perhaps address those. So I at least need to be communicating that I'm willing and open to not just shut down the conversation and say, I can't do anything about that. This is the only thing I can do. Because if that's the road that you're going down, you will find yourself not necessarily achieving the outcomes that you desire. I think the other way, and just to wrap this up, is to also understand that when that is not the case, and more often than not, most traditional researchers will not find that they get the kind of relationships that they want because they are unwilling to go outside of the box of what they determine is best for the community. And you have to be careful that you never are framing that you know what's best for someone else. Now, that is not to say that there may be times in that process of educating and informing that maybe there's some things going on that the community members and organizations might not fully know is happening. And that doesn't mean that you don't share that knowledge, but you have to share the knowledge. You're not the author always of the knowledge or the keeper of the knowledge. So I just will stop there by saying that you have to be willing to embrace, to listen, to understand, to not control, and find ways that if there are other issues in the community that are important to them, to find ways to make sure that you respect them and acknowledge them and try to find other opportunities to be able to help address them. And if you can't, to be honest and clear that you can't do that. And so I think that is those are the most important nuggets that I have learned over my years of really working with communities and working with community organizations.
Thank you very, very much, Janice. I think you should be on MSNBC, the health side of things, giving up that kind of information that would make things go further. But I have a part two to my question, and that is, and I'll give you 2 minutes to answer the question.
All right, I got it. 12:36.
Okay, and so my second part of that question is, what do you do when what you think is both important, and I think you actually answered some of this, and actionable from a health perspective is different from what the community partners that we're collaborating with regard as important to actually focus on and is actionable?
And I do think that I answered it. But I would just add this other little nugget to this is that we can't always be the takers of information and data, that we have a responsibility, particularly as researchers of color. We have an absolute responsibility. And if you don't want to take on this responsibility, then find another way to do your research. Because community engaged research, not everybody should do it, because there can be more harm than good done. But we have to be willing to give back. We have to be willing to show up. We have to be willing to be present, not only in the times when we want information from community members. And so the more that we build, you have to build relationship. If you've ever been in a relationship with anybody, whether it's your spouse or partner or whatever, you understand that what it takes to make that relationship work, and how it can fail. And it is communication, it is trust, it is understanding that it isn't going to always be 50-50. More often than not, it's not going to be 50-50. There are times when you need to do 80 and they're going to do 20 and vice versa. And so I think that we have to understand that we have the resources, we have the capacity and the capability, our community partners have that too. They may not have the resources in the same way, but we have to be willing to understand that this is a bi-directional relationship that we're trying to foster and build. And we have to be willing to also go out on that limb to make sure that the needs of the community that's important to them, we acknowledge it and we try to help address it. Okay, 12:38, I did my 2 minutes.
Thank you. You did your due diligence. And so now I'm going to move on to you, Ms. Chapman. If you want me to call you Rhonda, let me know.
Please,
But,
yes, call me Rhonda.
Rhonda,
please.
okay.
Thank you.
Okay, I'm here with my girls today. And so Rhonda, you have a lot of experience trying to align the work of the American Heart Association with researchers whose interests align with your organization's endeavors. What qualities stand out to you the most when determining what a researcher is, when a researcher is a good match for you to partner with? And can you also share an example of a productive and rewarding partnership with us as well?
Well, I'm going to start with the Center for Health Equity and Lisa Cooper, who I told Chidema, I said, you know, she is who I aspire to be. Mm-hmm. And a lot of the work that I have done over my career with AHA is really reflective of what I've watched and learned from Lisa Cooper for many, many years. And, you know, Lisa, if people don't tell you, you are the bomb. I'm telling you, you're the bomb.
So, bomb.
Yes. I'm going to jump on what Janice said. And Janice, I think this is so funny because we're working on a project together right now with Julia Wolfson around diabetes and a research project, and everything that Chidema said and what you just said so perfectly captures the way we are approaching that work that I'm definitely going to share that as an example. But Chidema, you had promised to say our favorite line, nothing for us without us. I live that every time I think about anything that I do for the American Heart Association. And I work for a big organization too, so I understand working at a Hopkins. Believe me, it's a working at a heart association too. So what I make sure I do in the way I approach the work in the community is to really nothing for us without us. And I consider me part of us. And that's the other thing. I am the community. I am part of the community. My family is part of the community. My friends are part of the community. We are the ones that ultimately benefit from the things that are done in research. And I think we don't talk about that enough, you know. And what's so exciting for me in this kind of community-based participatory research, I've done research with heart. I've been here 35 years. I staffed the research committees, and you didn't see results from research for 10, 15 years in our old traditional way of seeking answers to problems. Now we're seeking answers to problems that are impacting people's lives right now. And we're asking them right now, what are going to be the barriers that are going to prevent a solution for you? And so I think that goes back to what you said, Janice. Stop creating things for folks or doing research on and seeking answers to the questions they don't even have. That's not the question they have. So one of the things I will say with what we do at the Heart Association, every couple of years, we do a very thorough market assessment. And that market assessment is not a traditional just data gathering process, because I can pull health data. That's not a problem. I always go to the Center for Health, we pull a bunch of data anyway. But what I make sure we do as we embark upon setting our strategies for the upcoming years is engage stakeholders in looking at the issues that are priorities for the association, where we have the bandwidth and the content and the science to support impact. And then we ask stakeholders within these priority areas of focus, what are the issues within them that we need to think about addressing as we move forward with our strategies. One of this year, for right now, in the next couple of years, we're looking at nutrition insecurity. We're looking at women and heart disease and poor maternal health outcomes. We're looking at management of chronic conditions, hypertension, diabetes, and we're focusing on tobacco and vaping, but under the framework of youth engagement and empowering youth and community voices to advocate for changes they need to see in the community that will support their behavior change and movement away from poor behavior. So under those 4 priority areas, then I start to look at and explore. I never start anything without exploring where are the best practices, who is doing the work already, where can I expand on relationships I already have, where can I bring in new relationships to support, and then I start making phone calls. One of the things I looked at with maternal health is, and I remember that meeting, Lisa, you all were doing the MAC grant, and Wendy and them started talking about maternal health, and I'm sitting in my chair just jumping up and down going, I'm calling her immediately after this. Wendy and I have already connected, and what I made sure she knew is the AHA had just recently released a research grant opportunity around maternal health outcomes. Wendy, we must pursue this. Let me help you. Let me help you think through, which my research team at National says, how do you get people to engage in these kind of research projects? Well, I go out because I, quite frankly, am a trusted voice in the community. And I have a lot of relationships in the community. And I go out and I share with them, this is an opportunity for us to work together with strong clinical partners that can help us bring resources to our community and then use their expertise to build strong programs and strategies that help improve health. It is a partnership, a collaboration, a clinical community connection. And I think that is probably the strongest path forward for research, is to really pursue this through the lens of a clinical community connection. So the 2 examples I'm going to share, Janice, I have to do this one because you were before me, is right now we're working with Julia Wolfson. And a few years ago, I had this idea that I thought, integrating, we have a kitchen in Baltimore. I know all of you are pretty familiar with it. I said, as we looked at diabetes, I said, one of the things that my family members had been telling me that they found difficult in managing their pre-diabetes and even their diabetes was cooking and eating. They just didn't know what to do. So I said, I wonder what the DPP class curriculum looks like. So I pulled it up and I looked and I did some research. I said, oh, well, participants are already saying the didactic is great, but we need hands-on experience in order to facilitate that behavior change, because it is a behavior change. So I reached out to Rhonda and said, I have an idea. I'd like to, think about creating a cooking series with our chef at our kitchen, integrated with DPP, because we don't want it to be a standalone. We want it to add on to the work you're doing. And can we look at this and pilot something for a year? Nisa and Megan, they're just great. And what we found through that work, that engaging people in cooking classes improve their retention rates in DPP, improve the weight loss, and improve A1C. That is a super, super win. So then here comes Julia back to Hopkins, who, by the way, had done the original evaluation on our kitchen concept that drove us to make it a skill-based strategy and not just a nutrition strategy. Well, Julia comes back with a DPP Cooks program that she's going to be researching and doing. Well, we did that. Let's bring Nisa in, and Janice is on the group, and Michelle, I think you're on it too, aren't you? Because she's a participant in the cooking classes at the kitchen. She tells us, no, y'all, that's not going to work. No, that recipe might not resonate with the folks we're trying to teach. So, I think the way we're approaching that DPP Cooks work, Janice and Michelle, I'm thrilled. I thought and I've seen the 2 notebooks, they are fantastic. We just had another call with the 2 groups about making a video series so we can look at how do we scale this, how do we make it available for others. But before we do that, we will talk to the facilitators to say, what are the questions patients ask? And we'll talk to the participants in our past classes. What do you like most about the classes? What are the skills you need us to hone in on? So before we develop, we will have gotten input from the end user. Nothing for us without us.
Thank
The
you.
other example I'll share is, I'm so excited, and I hope Yvonne is going to be up next. I'm just a part of the Hopkins family. I don't know why y'all just don't go ahead and give me a Hopkins badge. I pretty much am a Hopkins family member, but Yvonne and I met, and she has joined our board, so I'm so thrilled. But Yvonne Kamara-Mensah is just working on so much in hypertension. And, you know, as soon as I saw her get that HERN grant, I called her up and said, oh, I want to help you. We need to make this work in Maryland. And so we have subsequently looked at submitting for a grant for our work in faith-based community. And Reverend Hickman, yes, we will call you because we're going to do good things. But we wrote a grant, and we had the 5 churches that are going to participate. We had the pastors from those churches involved in writing the grant. They reviewed it.
Excellent.
They said, no, we need this many copies. Well, let's balance. More membership over here. Let's balance and get more here and less here. It was an amazing process to write the grant in collaboration with those who seek to serve. Oh, Nancy, I love you. And Nancy also taught me so much about human-centered design, and I have become a fan and a promoter that, again, Nancy, I know you take this to heart because nothing for us without us. When we did work with Nancy in doing human-centered design, it was for the purpose of understanding the tools that would resonate and be used by the patients that we were designing for. Nothing worse than creating something that no one will ever touch. So, Reverend Hickman, that's what I wanted to add. I just really enjoy and value with a capital V, my relationship with the center and every one of you that I work with. And you know what, I consider it is a relationship, because whether I'm calling you to ask you for something or whether you're calling me to ask me for something, I'm here for you and you're here for me. And it might not be we're working on anything right now, but when Chinema said, Rhonda, I need you to do something. Yes. Okay, now what do you want me to do? And that's the way I like to work with the center. So thank you for allowing me to have this opportunity. And I hope to continue to work for you guys many, many years.
Thank you so very, very much. Between you and Janice, Michelle, as I bring you forward with these questions, we're going to have to be time sensitive, not to be disrespectful or disregarding of community voice. But given that you've been a member of the Center for Health Equity for 12 years, I am sure that you've seen a lot of different studies come and go. What has been your experience providing input on different projects, and what advice at this moment would you give to the community members to make sure that their voices are heard in the research process and understand and make them understand nothing for us without us? You're on mute.
Okay. Good afternoon, everyone. Thank you, Dr. Ebay, Dr. Cooper, Reverend Hickman, Dr. Bowie, and Miss Rhonda. This is an opportunity and a pleasure, and I'm so excited. Reverend Hickman, it's 11 years going into 12, so it was just 11 in January to help it out. And yes, 40 years is a long time to work, to be a part of, and want to be a part of. To me, that's most important. And I think that all the programs I've been in, whether it's Rich Life, Health Equity, the ACT study, 5+ Beans and Nuts, they've all been helpful to me. Because as a patient, I have diabetes, I have high blood pressure, I have cholesterol, I take an aspirin. But you know what? All that has been beneficiary and very, very helpful. And the reason it has been because I took time for myself. I have taken time in life for a lot of people and helping people. I didn't take it for myself. It wasn't until I turned around 50 or so, I realized I had these health issues. Coming in the rooms with all you guys and all the researchers, it has been helpful, respectful, trustworthy, and trust is a great part of it because I had to accept and understand you're doing research on me. As I go back and I piggyback on what Dr. Bowie has said and Ms. Rhonda has said, and I don't want to lose my little head wrap. However, it's important. That's right. I'm going to bring the humor. I love humor. So that was a good laugh and it was supposed to happen. It is important that you open your ears, shut your mouth, listen to what the doctors are telling you. What the researchers are saying, they have experience, but the community has more experience because we're the ones you're doing the research on. And we want to be able to trust what you're saying and give it each doctor, researcher, truth. It's important. Talk to your doctors. Guess what? They're human beings. It's important to know when you come into our communities, we want to be able to trust you. We have a language in the community, which has been said already. The community knows what it needs. You come in with one thing, and if it's not the need of the community, you will not get a result. It is important when you come into the communities, whether it's the stakeholders, whether it's the patient, whether it's just someone in the community who just is there to say, I like what you're doing, I see what you're doing, and I like to be a part of. That's important. Yes, I have been able to lose weight. Yes, I have been able to monitor what I do. Yes, I use a pill box because if I did not, I wouldn't remember what pill I took from one day to the next. But because I do what has been suggested, because I have a mind of my own and I'm able to do things to help myself, it has helped to improve my health because I want to live a long time. As in a video that Hopkins has, when I said my mom passed of a massive heart attack, she was 68 years of age. I am now 72. It has been an uplift to my upbringing. And I like to say another thing. This is Women's History Month. Today is my mother's birthday, my grandmother's birthday. She would be 139 years of age. I have to say that today because it's community. And if I didn't, I'd feel bad the rest of the day that I didn't share that little piece of history with this committee. I thank the people on this committee and everybody who comes into these CAB meetings, community engagement meetings with us, that they realize that we do have something to say. I like the word relate. That is most important. We have to have transparency. We have to have respect. We have to know that just because you know a little bit more than me, I was a baby at one time, I got your attention when my butt was wet, it needed to be dry. So the fact of the matter is, it is important that we talk, we'll not be afraid to talk, we respect one another, and everybody can help us bring forth change. Now is the important time for change. We see the world changing. We know as African Americans, we know as individuals, things have to change more than just salary. Now you realize our worth is worth. Women have been important since the beginning of time. We are the vessel. We are the ones that can get things going. We are the ones that know what's going on. We are the ones in the community that the people are not afraid to talk to so that we can come into these meetings to share with you the concerns of the community so that you can help the community to get healthy, to trust you, and to want to be a part of.
All I can say is amen, and we will pass the plate after this video.
Go on, Reverend.
I'm telling you, that was a preached word. Praise the Lord. Thank you very much for the three of you. I think that you've already answered our last question of the challenges and the benefits of being involved in community engaged research. But I think in the conclusion of this, that there is so many insightful comments and so many good gifts that you've given us today, nuggets that you have given us, that we don't have time to actually allow those out there in the virtual panel to actually ask questions of us. We're going to be respectful and move forward with the next panels, which will be breakout sessions. I love you all, and I look forward to working with each of you ongoingly. We will get done the work that needs to get done, and we will help to make research also translatable when it has been successful to the major part of the community.